Okay, let's unpack this. We are tackling a topic that many in the perioperative field consider, well, the ultimate physiological and technical test, pediatric anesthesia.
It really is.
And this deep dive, it's really tailor-made for those of you who need to move past just rote memorization. Our mission today is to build a physiologically driven blueprint for clinical safety and, of course, for exam success, really understanding the absolute why behind every single rule.
Indeed. We're here to establish a core professional truth, and that is that the needs of infants and young children are fundamentally different from those of adults. It's a physiological demarcation line.
It's not just that they're small adults.
Not at all. Every choice, from the size of your breathing circuit to the microgram dose of your sedative, it has to be filtered through this lens of developmental immaturity. If you're preparing for a national exam or, stepping into a pediatric operating theater, you have to internalize that critical events in this population. They're most often cardiac or respiratory in origin.
And they happen fast.
They happen faster and are far less forgiving than in adults. The margin for error is it's razor thin.
So before we get into the really heavy physiology, we have to establish the basic vocabulary, right? The age classifications. This isn't just bureaucracy. It's the foundation for stratifying risk and managing expectations.
It's our essential starting point. When we talk about these patients, we have to use distinct developmental periods because the physiology changes so dramatically between them.
Okay, so let's lay them out.
First, you have the neonate. That's the first 28 days of life. This is the period of the absolute highest risk. You have this profound physiological transition from fetal to adult circulation, and they are at their most vulnerable.
28 days, okay.
Then you have the infant, which spans from 28 days up to 1 year of age. Now, they retain many of those neonatal vulnerabilities, but they're also rapidly developing.
And after that?
The child. This is a broader category, typically from 1 year to 12 years. And what's interesting here is that by age 5 or 6, many physiological systems, especially the airway structure, start to resemble the adult model. But their metabolic rates, they remain very high.
And finally, adolescence.
Right. The adolescent runs from about 13 to 17 years. These patients are often treated pharmacologically like adults, but their psychological needs and their risk profiles still require that pediatric sensitivity.
And the sources are absolute unequivocal here. The stakes are they're astronomical. Perioperative mortality in neonates and infants is several times higher compared to older kids. So we need to focus on what we're calling the high-yield safety triangle to counter that risk.
The necessity of rigor just cannot be overstated. This high-yield triangle consists of 3 non-negotiable principles that really determine safety in the first minutes of any case.
Okay, what's the first pillar?
The first is dosing accuracy. Just think about the absolute numbers we're dealing with. In a small infant, the total blood volume might be, 300 to 400 milliliters? Exactly. So if you miscalculate a potent drug dose by just 1 ml, that might represent a 20% error in the intended concentration. Small absolute body volumes mean that tiny miscalculations can have catastrophic, significant implications.
So no eyeballing the dose, no guessing the weight.
Absolutely not. Weight determination is mandatory for everything. For dosing all medications, for precise fluid administration, for blood product resuscitation. And if the weight is unknown in a critical emergency, we rely on tools like length-based tapes.
The Broslow tape, for example.
Broslow is the most famous example, yes. It's a critical estimation tool. These tapes give you a color-coded guide for weight, equipment size, drug doses. It immediately reduces the dangerous cognitive load when you're under immense pressure. It's a life-saving shortcut based on measurement, not on guesswork.
Okay. That handles the medication input. The other 2 pillars of safety are about constant monitoring of the metabolic environment. You're talking about temperature and glucose. Why are these 2 so volatile and so important in infants?
It comes down to their immense surface area to body weight ratio. They are, physiologically, they're built like radiators.
Radiators. I like that.
So homeostasis control is paramount. Because of that proportionally large surface area, infants and neonates lose heat incredibly rapidly through radiation, convection, evaporation. They also can't shiver effectively. They rely on something called non-shivering thermogenesis, which uses up their brown fat and can deplete glucose stores very quickly.
Which means active warming isn't optional.
It is non-negotiable. Everything has to be warm. The operating room, the fluids, the blood, the skin. Preventing inadvertent hypothermia is an active, continuous process that affects everything from coagulation to cardiac stability.
And with glucose, you said we're walking a tightrope.
Precisely. Glucose monitoring is critical.
Yeah.
We're trying to prevent both hypoglycemia and hyperglycemia. Hypoglycemia is dangerous because infants have very limited glycogen stores and high cerebral metabolic demands. A drop in glucose can quickly lead to cerebral energy depletion, seizures, and long-term neurological injury.
And on the other side,
Hmm?
hyperglycemia.
Hyperglycemia is also associated with poor neurological outcomes, especially in settings of cerebral ischemia or during complex surgeries like cardiopulmonary bypass. We also have to monitor ionized calcium very closely, particularly in critically ill young patients, because impaired calcium homeostasis is common, and it directly impacts their calcium-dependent myocardium.
All right, this is where we shift to anatomy, which is probably the single highest yield section for both clinical safety and exam prep. The core message is clear. Children do not have small adult airways. Let's start with just positioning.
If you're an examiner, this is the section you ask about first, because airway management dictates life or death. The first difference is obvious when you look at them: the proportionally larger head and prominent occiput.
Right.
So imagine an adult resting their head flat on a table. No problem. Now imagine a small child with this oversized head resting on that same flat surface.
That big occiput is going to push their head forward into flexion.
It forces the neck into passive flexion, exactly. And that flexion naturally obstructs the posterior pharynx. So the optimal head position is not the classic sniffing position we teach for adults. It's a truly neutral alignment.
How do you achieve that?
You often need to place a small shoulder roll or a folded towel under the shoulders. This elevates the trunk and brings the external auditory meatus and the sternal notch into alignment. This simple maneuver gives you the best possible geometry for mask ventilation and for laryngoscopy.
Okay, so we've positioned them correctly, we get inside the mouth, and the anatomy immediately sets up the next challenge.
That's the issue of the oral structure. They have a relatively large tongue compared to their small oral cavity. We call it relative macroglossia. So once general anesthesia abolishes that pharyngeal muscle tone, this oversized tongue or glossoptosis can easily cause complete upper airway obstruction.
Which is why a jaw thrust is one of the very first things you do.
Almost immediately upon induction: jaw thrust, chin lift, and maybe an oral or nasal airway. We also have to be incredibly meticulous about avoiding compression of the submandibular soft tissues when we're mask ventilating, because that just pushes the base of that large tongue further back.
Now let's go deeper to the larynx. Its position is different, and the structures themselves are distinct.
Yes, the laryngeal location is both more anterior and more cephalid than in an adult. In a newborn, the glottis sits at about the C3-C4 vertebral level. In an adult, it's down at C6.
So it's higher and more forward.
Which makes visualization more difficult.
Yeah.
You often need a deeper insertion of the laryngoscope blade. And furthermore, the epiglottis itself it's long, it's floppy, and it's often E-shaped or omega-shaped. It protrudes posteriorly.
And that shape dictates your choice of blade.
It does. It necessitates the use of a straight laryngoscope blade, like a Miller blade. It's designed to physically lift that floppy epiglottis up to expose the vocal cords. That's a direct contrast to the curved Macintosh blade, which sits in the vallecula in adults.
Okay, let's get to the cricoid cartilage trap. This is the anatomical detail that dictates the entire philosophy of pediatric tube sizing and airway trauma. Why is the cricoid so dangerous?
Because up until about age 5, the narrowest point of the pediatric airway is the cricoid cartilage. It's a complete cartilaginous ring, which gives the airway a funnel shape. The adult airway, in contrast, is narrowest at the glottis, at the vocal cords.
And that funnel is the critical difference.
It is. The mucosal lining around that cricoid ring is very loosely bound, which makes it incredibly susceptible to edema following instrumentation or infection or any kind of trauma.
And this is where the physics of airflow just slams right into the physiology of the infant.
Precisely. This is the critical safety fact that must stick with every single practitioner. Because of Poiseuille's law, which states that resistance is inversely proportional to the radius to the fourth power.
Meaning a tiny change in diameter has a massive effect on flow.
A massive effect. If you take a standard small airway, a mere 1 millimeter increase in mucosal edema at that cricoid level can decrease the cross-sectional area by a staggering 74%.
74% occlusion.
Yeah.
From 1 millimeter of swelling. That's almost complete obstruction. It's an instant life or death crisis, like post-intubation group.
It is, and it's the reason we must be millimeter perfect with our endotracheal tube sizing and use the gentlest, most meticulous technique possible. If an adult airway swells by 1 millimeter, they might still have 90% of their airway left because the initial diameter is so much larger. For an infant, that 1 millimeter is the difference between breathing and severe respiratory failure. This single concept dictates everything.
We've established the structural limits, now we look at the engine. Let's explore the dynamic differences, starting with the respiratory system. Why is the pediatric patient what you call a rapid desaturation risk?
It's a perfect storm. It's high demand meeting very low reserve.
Okay, break that down. What's the high demand?
The high demand is their metabolic rate. Neonates and small infants have double the basal metabolic rate, and therefore double the oxygen consumption, or VORO, compared to adults. We're talking about 6 to 8 milliliter versus 3 to 4 for an adult. They're burning through oxygen twice as fast, proportionally.
So they're essentially running a marathon while they're lying still.
That's a great analogy. Now, you combine that high consumption with their second problem, low oxygen reserve, or what we call functional residual capacity, the FRC.
The FRC is the O reservoir in the lungs.
It's our safety reservoir, exactly. And it is intrinsically reduced in infants due to several structural factors. Their chest wall is much more compliant. The ribs are cartilaginous and more horizontal. This limits that bucket handle expansion.
So the chest wall kind of collapses inward?
It fights against lung expansion, yes. And at the same time, the lungs themselves have relatively reduced compliance. They have fewer, smaller alveoli until around age 8. And the small airways also tend to collapse at a higher lung volume.
So high VORS plus a low FRC. That is the formula for an immediate crisis the second they stop breathing.
Precisely. The clinical consequence is catastrophic. During periods of apnea, like during laryngoscopy or difficult intubation, their oxygen saturation drops like a stone. An adult might tolerate 60 to 90 seconds of apnea before the SPO alarm starts screaming. An infant, you might get 20 to 30 seconds.
Which makes diligent, effective pre-oxygenation absolutely critical.
You have to. You must replace that limited FRC with 100% oxygen to buy yourself the maximum amount of time.
And to make matters worse, anesthesia itself reduces FRC even further.
It does. General anesthesia abolishes the active mechanisms that infants use when they're awake to maintain their FRC. While conscious, they maintain lung volume by contracting inspiratory muscles and performing a partial glottic closure at the end of expiration. The moment we give them propofol or a volatile agent, we take that mechanism away.
And the lung volumes just fall.
Immediately. It leads to rapid atelectasis and significant VQ mismatch, which just compounds that desaturation risk even more.
We mentioned Poiseuille's law with the anatomy, but it's just as relevant here dynamically.
Absolutely. The high baseline airway resistance due to those small diameters means that any mucosal edema, any secretion, any bronchoconstriction rapidly and severely impairs airflow. A minor cold that gives an adult some congestion and snoring might lead to complete respiratory failure in an infant.
And then there's the paradoxical ventilatory drive.
This is a major, major difference. In neonates and infants, especially preemies, the ventilatory drives are immature. Unlike adults where hypoxia and hypercapnia robustly stimulate breathing, in this age group, they can actually depress ventilation. A severe drop in oxygen might signal the brain to just stop trying, which explains their propensity for postoperative apnea.
Okay, so if the respiratory system is working against us, we turn to the heart. The pediatric heart is structurally and functionally distinct, and it's summarized by that mantra. Cardiac output is heart rate. So why is their stroke volume essentially fixed?
It's rooted in the structure of the immature myocardium. It's less compliant, meaning it's stiffer, it doesn't stretch as well, it has fewer contractile proteins, and a higher proportion of non-contractile tissue. And crucially, the cells have reduced sarcoplasmic reticulum stores.
Why does that matter for contractility?
Because the myocyte becomes significantly more dependent on exogenous or extracellular calcium for contraction. If their calcium levels fluctuate, or if we introduce a drug that affects calcium movement, the infant heart reacts instantly and profoundly.
So this structural limitation means the Frank-Starling mechanism, our adult safety net where more stretch equals more force, it's severely blunted in children.
That is the clinical outcome. Stroke volume is fixed. The heart is already operating near the top of his Frank-Starling curve. So trying to increase preload by giving more fluid beyond filling pressures of, say, 7 to 10 millimeter Hg, it yields only minimal increases in stroke volume. They can't compensate for hypovolemia by squeezing harder or filling more.
So if SV is fixed, then the calculation for cardiac output, or CO, is simple. CO is primarily rate dependent.
Absolutely. The child must increase their heart rate to increase their cardiac output. And therefore, the danger of bradycardia is immediate and existential. It's the most common pediatric arrhythmia, and because they can't increase stroke volume, a drop in weight instantly reduces cardiac output.
And what's the most common cause of that bradycardia?
Hypoxia. Hypoxia is the most frequent cause, and it can rapidly, within seconds, progress to a systole. In newborns, A heart rate below 60 is treated with the same urgency as an adult cardiac arrest. It's an absolute must-intervene moment.
And this structural limitation also makes them exquisitely sensitive to our drugs.
Yes, neonates and infants are extremely sensitive to negative inotropic agents like volatile anesthetics and propofol, which depress myocardial contractility. They're also sensitive to beta blockade. And since their compensatory mechanisms like vasoconstriction are immature, administering these drugs can quickly lead to profound hypotension. It requires slow, cautious titration.
To properly dose and predict how drugs will accumulate, we also have to factor in the maturation of their other systems, like renal and hepatic function.
Right, those systems are simply not fully operational yet. The renal and hepatic functions are incompletely mature, particularly in the first year of life. This specifically impacts drug metabolism and excretion. We talk about phase 1 and phase 2 metabolism. Phase 2 reactions like glucuronidation, which is where you stick a sugar molecule on a drug to make it water-soluble so it can be excreted, those are often immature until about age 3.
And that delayed maturation is critical because it's going to prolong the half-life of many drugs.
It does. It creates a real accumulation risk for certain drugs that rely on glucuronidation for clearance. This means we have to think very carefully about dosing intervals for repeat doses, or we risk causing unexpected toxicity.
Does the physical size of the organ play a role?
The liver is a good example. It represents a much larger proportion of body weight in newborns, about 5% compared to adults, where it's only about 2 to 2.5%. But even though it's proportionally larger, the specific enzyme systems like the CYP450 isoenzymes needed for drug metabolism are functionally immature. This combination results in highly variable, age-dependent drug profiles.
And finally, let's touch on the critical and evolving concern about CNS sensitivity and neurotoxicity. This isn't just about immediate recovery, it's about long-term outcomes.
This is maybe the most challenging and debated area in our field today. The brain is undergoing this intense period of development, synaptogenesis, particularly in the first few years of life. Now, exposure to anesthetic agents, notably those acting on GABA and NMDA receptors, has been associated with widespread neurodegeneration in animal models during these vulnerable periods.
But the link in humans isn't as clear-cut.
It's not. Definitive causal links in humans are still being investigated, and there are so many confounding factors, like the underlying surgical condition itself, that complicate the data. But it demands that we minimize exposure and monitor very closely. It also highlights why standard depth of anesthesia monitoring, like EEG or BIS, is so challenging because of the age-dependent patterns in brain activity that haven't fully matured.
Okay, pharmacology. This is clearly more than just scaling down a dose. If we're serious about exam success and clinical safety, we have to move past simple mg/kg calculations and really embrace the underlying pharmacokinetic concepts.
We must. Let's look at the nuances of pharmacokinetic principles. First, distribution. Infants have proportionally more total body water and less fat compared to adults.
Right.
This means for water-soluble drugs like succinylcholine or propofol bolus, they often require a higher weight-adjusted dose initially.
That seems counterintuitive. They're small, yet they need a bigger dose per kilogram for some drugs.
Exactly, because that dose is being distributed into a larger proportional volume of water to achieve the same target plasma concentration. Now let's use the prime example for clearance. Propofol. Despite some enzyme immaturity, children often show a shorter elimination half-life and a higher plasma clearance for propofol compared to adults.
And why is that?
Because they have a proportionally larger cardiac output and hepatic blood flow relative to their body mass. This delivers the drug to the metabolizing tissues, the liver, the kidney faster. This means for maintenance of TIVA, or total intravenous anesthesia, children may require significantly higher weight-adjusted infusion rates, sometimes up to 250 millisievertcologene, which is substantially higher than adult maintenance doses, knowing that is non-negotiable for safe TIVA.
Switching to volatile agents, the NEET-SS concept is central, but its value changes wildly based on age.
The minimum alveolar concentration, or MEAs, is not a flat line across age. It is actually highest in infants between 1 and 6 months of age. Then it declines slowly until adulthood.
So infants are actually the most resistant age group to the hypnotic effects of volatile agents.
That's right. Which agent is preferred for induction then? It's sevoflurane. It's the preferred agent for inhalation induction globally. Its kinetics are rapid, and that's hastened by the physiology we've discussed, the high minute ventilation and low FRC. And critically, it's non-pungent. It has a low incidence of airway irritation, coughing, or laryngospasm during induction, which makes it ideal for an uncooperative young patient.
What about Disflurane? It has the fastest on-off kinetics.
Desaturate is indeed very fast, and it offers the advantage of rapid emergence because of its very low blood solubility. However, it's far more pungent. It's associated with a high incidence of airway reactivity coughing, breath holding, and agitation or delirium during induction and emergence.
So you wouldn't use it for an inhalation induction.
Generally not. Due to its airway irritancy and the risk of a sympathetic surge, it's usually reserved for maintenance in specific cases, but not for inhalation induction.
Before we move on, we have to issue a clear propofol infusion syndrome, PIS, warning. This is a high-stakes complication.
This is a definitive clinical rule. Propofol is not recommended for prolonged sedation in critically ill pediatric ICU patients, especially at high doses, typically over 4 to 5 milligoing kiloations. PIS is associated with high mortality and involves rhabdomyolysis, metabolic acidosis, hemodynamic instability, multi-organ failure. The risk increases with duration and dosage.
So you need alternative sedation strategies in the ICU.
For long periods, absolutely. And finally, let's just revisit the profound cardiovascular impact of volatile agents. They cause hypotension very readily in children, not just because they depress contractility, but because the compensatory mechanisms reflex peripheral vasoconstriction and tachycardia are less developed in infants. The heart can't squeeze harder, and the blood vessels can't tighten up as effectively. This just exposes that fixed stroke volume vulnerability all over again.
Okay, preoperative assessment. This shifts from testing cooperation to really forensic history taking and visual inspection, but we have to start with the most basic safety measure, fasting.
Fasting guidelines are an absolute safety mandate, and they have to be age-specific. The general rule is 2 hours for clear fluids, 4 hours for breast milk, 6 for formula or non-human milk, and 8 hours for solids. Adherence is critical.
And in trauma, all bets are off.
In trauma, a child should always be considered to have a full stomach. The risk of aspiration is high, especially with a rapid induction.
So how do we approach the difficult airway assessment challenge when standard adult tests are completely useless?
We rely almost exclusively on history and visual inspection. The history includes asking parents about noisy breathing, snoring, any previous difficult intubation history, or known syndromes. Visual inspection means looking for physical signs of risk, facial dysmorphias, stridor, dysphonia. Things like the Malampati score are worthless due to a lack of cooperation.
What are the key syndromes or physical signs that should immediately trigger a difficult airway alert in your mind?
You have to memorize the common anatomical risks. Look for conditions that cause macroglossia, a large tongue like Down syndrome or Beckwith-Wiedemann. Check for micrognathia, a small recessed jaw, which forces the tongue and larynx anteriorly. You see that in Pierre-Robin sequence or Treacher-Collins syndrome. These patients often require immediate fiber optic scoping or special positioning.
Are there others?
Yes. You have to recognize complex metabolic disorders like the mucopolysaccharidosis Hurler and Hunter syndromes. The deposition of storage material leads to stiff, bulky airways, short necks, and severe rigidity. They can be extremely challenging for both mass ventilation and intubation.
The psychological preparation is just as important as the physical. How do we use pre-medication effectively?
Preoperative anxiety is intense, particularly in that 2 to 6-year-old age group. And intense anxiety translates to agitated, risky inductions. So pre-medication aims to manage this, either through behavioral techniques, like allowing parental presence at induction, or with pharmacologic pre-medication, typically oral midazolam.
And a calm induction is a safer induction.
Exactly. Reducing that anxiety not only comforts the child, but it ensures a smoother, less agitated induction, which minimizes the risk of laryngospasm and bronchospasm.
So when it's time to induce, the choice of agent is often just a matter of logistics, right? Can they tolerate a needle or not?
That's the practical reality. The agent choice is dictated by cooperation. For induction is usually preferred in older cooperative children to secure the airway rapidly. But for younger, needle-phobic kids, inhalational induction, almost universally with cephalosporin, is favored to minimize stress.
We touched on this, but let's elaborate on the inhalational speed. Why is it so much faster in children?
It's the ratio game again. The induction speed is hastened by that combination of increased minute ventilation to meet their high metabolic demand and their decreased functional residual capacity, or FRC.
So you're putting gas into the lungs faster, and the mixing chamber is smaller.
Exactly. So you get this rapid alveolar equilibration. The inspired concentration quickly matches the alveolar concentration, and that leads to a quick onset of effect and rapid unconsciousness.
In emergencies, like trauma, we rely on rapid sequence induction, RSI. What are the mandatory pediatric modifications?
The standard tenets of RSI apply pre-oxygenation, cricoid pressure, although its use is debated, and a rapid, non-ventilated induction. However, the modification is crucial. You have to recognize the extremely short time to desaturation because of their high VRO and low FRC. This mandates absolute efficiency.
You're going to have time to spare.
None. You must minimize the time spent apneic during intubation attempts. If an intubation attempt fails, you have to reestablish ventilation immediately. You do not have the 60 or 90 seconds of apnea reserve an adult might have. You might have 30 seconds, maximum.
Let's move to airway management. This requires constant preparedness for collapse. What are the key techniques for mask ventilation when the upper airway gives way?
You have to be prepared for upper airway collapse, which is often caused by that large tongue. This requires a combination of maneuvers, chin lift, jaw thrust, and the careful application of continuous positive airway pressure, or CPAP, via the mask to stent the airway open.
And there's a key don't here.
The absolutely critical technique to remember, which contrasts with some adult maneuvers, is to avoid pressing on the submandibular soft tissues. Compression there just exacerbates the obstruction by driving the base of that large tongue further into the pharynx.
Supraglottic airway devices like LMAs or iGels are standard in adults. How do they fit into the pediatric picture?
They're increasingly used, especially for short procedures, and they're excellent rescue devices. However, you must select the size meticulously. Unlike adults, SGAs must be sized very carefully to avoid causing gastric insufflation or airway trauma. They provide an excellent seal, but are still considered temporary, especially if the aspiration risk is high.
Okay, let's talk endotracheal intubation. The sizing formula is a classic, but the choice between cuffed and uncuffed tubes has evolved a lot.
The standard sizing formula for the ETT diameter in children over 2 is age in years divided by 4 plus 4. That gives you a starting point. But given that cricoid trap, you must always have tubes one size larger and one size smaller immediately available.
What's the current thinking on cuffed versus uncuffed ETTs? This used to be a fierce debate.
The debate has largely been settled by technology and safety data. Traditionally, uncuffed tubes were used in kids under 6 because the cricoid provided the functional seal. However, cuffed ETTs are routinely used today, even in very young children, especially those who are critically ill, require specific ventilation targets, or need mechanical ventilation for extended periods.
Why the shift?
Because cuffed tubes reliably maintain a definitive airway, they ensure adequate ventilation, and, most importantly, they avoid the risk that comes with repeated tube exchanges if a leak develops. The absolute safety requirement, however, is meticulous maintenance of a low cuff pressure, ideally less than 25 centimeters of HO.
To protect the tracheal mucosa.
Exactly. Monitoring that cuff pressure prevents a decrease in capillary blood flow, which prevents the subsequent edema and post-extubation croup that we fear so much.
Finally, the disaster scenario, the complete difficult airway where ventilation and intubation fail. How does the rescue plan differ from an adult's?
This is a high-stakes emergency, where procedural knowledge is everything. Needle cricothyroidotomy is the preferred temporizing measure over a surgical cricothyroidotomy in children, especially those younger than 12.
Why is that?
Because the cricothyroid membrane in children is just tiny. The surgical approach is technically very difficult and carries a high risk of damaging the vocal cords and the cricoid cartilage itself. A needle cricothyroidotomy with jet ventilation buys you time until a definitive, safer airway can be established, maybe with fiber optic assistance or surgical support.
Okay, the maintenance phase. This is dominated by vigilance over fluid balance and preventing metabolic catastrophe. Let's focus on fluid management and why pediatric hypovolemia is so dangerous.
Hypovolemia is terrifying because it is the single most common cause of perioperative cardiac arrest in children. This makes it the highest priority safety warning.
And why is it so insidious?
Because children compensate brilliantly. Until they can't, they maintain their vital signs, heart rate, blood pressure, until they reach a stage of significant, profound compromise. We estimate 25–30% blood volume loss.
So just looking at the monitor won't tell you the whole story.
Not at all. It makes clinical assessment of blood loss, looking at skin color, capillary refill, even vital signs, extremely challenging and unreliable. We have to rely on accurate calculation, weighing sponges, and just maintaining a very high index of suspicion.
What are the goals of fluid management?
The goal is tripartite: meeting maintenance requirements, often with the 4-2-1 rule, replacing any preoperative fluid deficits from fasting, and compensating for ongoing losses like third space losses or blood loss. For emergencies like severe trauma, if IV access cannot be obtained rapidly.
What's the benchmark for rapidly?
The standard benchmark is after 90 seconds or 2 failed attempts. At that point, intraosseous I/O access is mandatory, and I/O allows for the immediate, rapid delivery of adequate fluid volumes and blood products for resuscitation.
Shifting to mechanical ventilation during maintenance, what are the preferred modalities?
We aim for lung protective strategies. A tidal volume between 6 and 10 mQ/K is acceptable, but you want to avoid going over 10 due to barotrauma risk. We often favor pressure-controlled ventilation, PCV, over volume-controlled VCV,
And why is that?
because PCV provides a decelerative flow pattern and automatically limits the peak inspiratory pressures, which is safer given the variable compliance of the pediatric chest wall. And furthermore, positive end expiratory pressure, or PEEP, usually set at 5 centimeters of HO, is vital to prevent the rapid development of atelectasis that happens when they lose their FRC mechanisms under anesthesia.
Regional anesthesia has really exploded in pediatric practice, hasn't it? It's moved from being a specialist technique to a standard part of multimodal analgesia.
Absolutely. Regional blocks, both central like epidurals and peripheral, carry a very high safety rate and low risk of neurologic complications, provided they're performed meticulously. Their value is in significantly reducing the reliance on post-operative systemic opioids.
Which have their own set of problems.
Right, opioids are major contributors to respiratory depression, sedation, and post-operative nausea and vomiting, or PONV.
And the key procedural difference compared to adults has to be reinforced.
The key difference is all about safety and patient immobility. Regional blocks are typically performed as an analgesic adjunct in anesthetized children. We prioritize the child's comfort and stillness over the adult requirement for the patient to be awake enough to report, paresthesia.
So you're relying entirely on landmarks and imaging.
Exactly. Anatomical landmarks, volume and pressure monitoring, and especially ultrasound guidance to ensure accuracy and safety.
The caudal block remains the highest yield technique for abdominal and lower extremity surgery. How do we assess that clinically?
The caudal epidural block is accessed through the sacral hiatus and is superb for providing analgesia below the diaphragm. To assess the degree of motor block achieved, which reflects the density and spread of the local anesthetic, we use the Bromage scale, which goes from 0 to 3.
And what does a high score mean?
A Bromage scale 3, for instance, indicates a complete motor block. It's characterized by the inability to raise the leg, flex the knee or ankle, or move the toes. This is often an exam question designed to test your understanding of block assessment.
Okay, monitoring. While standard monitoring is universal, what specialized or emphasized monitoring is non-negotiable in the pediatric population.
Continuous monitoring is the rule, and I would emphasize 2 non-negotiable points. First, continuous temperature monitoring is essential throughout the entire case because of that high hypothermia risk. Every minute spent cold complicates recovery. Second, capnography is absolutely essential. It is not an optional monitor. It is mandatory for immediate ventilation assessment, detecting circuit disconnections, recognizing metabolic changes like malignant hyperthermia, and of course, confirming ETT placement.
And invasive monitoring is just technically harder in these small patients.
It is. Invasive monitoring is technically difficult and thus less frequent. Pulmonary artery catheters are rarely used, not just for technical reasons, but because in children with intracardiac shunts, which are common in congenital heart disease, pulmonary flow has no obligatory relationship to systemic output.
So the data from it would be misleading.
Completely misleading for assessing systemic perfusion. Instead, we rely heavily on specialized, less invasive techniques like transesophageal echocardiography, TEE, with Doppler flow imaging to critically assess myocardial function, volume status, and the integrity of surgical repairs during cardiac surgery.
Let's apply these principles to a few common surgical scenarios, starting with tonsillectomy in a child with obstructive sleep apnea or OSA.
This is a textbook example of risk stratification. Children presenting for tonsillectomy often have severe OSA. Anesthetic agents significantly decrease pharyngeal muscle tone, which increases the collapsibility of an already compromised airway. The primary risk is postoperative respiratory depression and obstruction.
So the management is all about minimizing opioids.
Exactly. It requires aggressive multimodal analgesia, using regional analgesia like local infiltration, paracetamol, and NSAIDs to minimize the need for opioids, which can cause life-threatening respiratory depression in an already vulnerable patient after surgery.
And the high-stakes emergency, post-tonsillectomy hemorrhage.
This is the critical scenario that combines every single risk factor. The patient is anxious, distressed, and often significantly hypovolemic from both obvious and occult blood loss from swallowing blood. They have a full stomach, which increases the aspiration risk immensely. And often, you're facing a difficult airway because blood may be obscuring your view.
It's a perfect storm.
It is. The protocol requires immediate fluid resuscitation, meticulous preparation for RSI, and having a solid plan for a failed airway that's obscured by bleeding. It's one of the most dangerous pediatric emergencies we face.
Let's touch on congenital heart defects. How does the physiology of tetralogy of Fallot, or TOF, dictate anesthetic management?
TOF is a classic case where understanding the shunt dynamics is everything. It involves a ventricular septal defect and pulmonary outflow obstruction, which creates a right-to-left shunt. Anesthetic management has to maintain systemic vascular resistance, SVR, and prevent a drop in pulmonary vascular resistance, PVR.
The goal is to push blood toward the lungs, not through the shunt.
Exactly. So agents that cause excessive systemic vasodilation, like high-concentration isoflurane, must be used very cautiously or avoided entirely. They drop SVR, worsen the right-to-left shunt, and can precipitate a catastrophic cyanotic spell, or a TET spell. Maintaining SVR with judicious use of phenylephrine is often necessary.
And what about the critical role of the patent ductus arteriosus PDA in other lesions?
In many duct-dependent lesions, like transposition of the great vessels or critical aortic stenosis, the PDA is the only life-sustaining connection allowing blood mixing or systemic and pulmonary flow. In those cases, the anesthetic strategy is reversed. We actively use prostaglandins to keep that ductus arteriosus open until surgical intervention can establish a stable mixing circulation.
To master safety, we have to know the common failure points. The Pediatric Perioperative Cardiac Arrest, or POCA, registry gives us hard data on where things go wrong.
The POCA registry is crucial. It consistently confirms that cardiac arrest in children is overwhelmingly caused by respiratory or circulatory failure.
Let's break down the most frequent cardiac causes reported by POCA.
The top causes are, in order, hypovolemia, which we identified as the most frequent and most preventable cause, myocardial ischemia, which is often secondary to severe hypotension, hyperkalemia, especially in trauma or burns, and sudden arrhythmias.
And the rhythm is different from adults.
Yes. Bradycardia progressing to a systole is the typical rhythm. Ventricular fibrillation is exceedingly rare in primary pediatric cardiac arrest. This just reinforces that adequate volume and oxygenation are your first lines of defense.
And the leading respiratory events.
They include laryngospasm, inadequate oxygenation, often from equipment failure or difficult pre-oxygenation, and difficult or failed intubation. The history of closed claims analyses has shown that just adhering to minimal monitoring standards, particularly capnography, has been instrumental in reducing serious respiratory morbidity. It just highlights the value of vigilance.
Moving into the recovery room, what are the high-risk recovery issues for our youngest patients?
Two challenges really stand out. First, postoperative apnea, especially in former preterm infants, those born before 37 weeks gestation. These infants require mandatory continued cardiorespiratory monitoring post-extubation, often for 12 to 24 hours because of their immature ventilatory drives.
And the second one?
Emergence delirium or agitation. It's common, particularly after sevoflurane or desflurane. This involves a dissociative, often aggressive state of inconsolable crying. It's very difficult to differentiate from uncontrolled pain or hunger, and it demands careful assessment and sometimes targeted treatment with agents like propofol or dexmedetomidine.
Okay, neonatal anesthesia. This is the extreme physiological challenge. Immense risk concentrated in the smallest human body.
Correct. Neonates require specialized intensive care. Their immaturity touches every single system: an immature myocardium, high dependence on exogenous calcium, profound vulnerability to hypothermia, and the risk of persistent fetal circulation, or PFC.
Where they revert back to the fetal circulation pattern.
Yes, where hypoxia or acidosis triggers a reversal, bypassing the lungs. The margin for error here is essentially zero.
Let's use cardiopulmonary bypass, CPB, for cardiac surgery as the ultimate illustration of how different neonatal physiology is.
Neonates and infants undergoing CPB are pushed to biological limits that really define the boundaries of modern medicine. They require deep hypothermia, often cooled down to as low as 15 to 18 degrees Celsius, to reduce metabolic demand and provide neuroprotection during periods of circulatory arrest.
And they experience massive hemodilution.
Up to 3 to 5 times more dilution of their circulating blood volume relative to total body water compared to adults. This necessitates incredibly careful management of the prime composition with blood and albumin.
And the pressures they run their systems at are barely perceptible by adult standards.
Their low perfusion pressures are maintained between 20 and 50 millimeter Hg, which is unthinkable for an adult. Furthermore, because of the significantly greater ratio of blood volume to the non-endothelialized surface area of the CPB circuit, neonates and infants have a heightened, exaggerated systemic inflammatory response. Post-CPB management often requires techniques like modified ultrafiltration to remove excess water and inflammatory mediators to stabilize their circulation.
So if we connect this entire spectrum of discussion to the bigger picture,
Mastering pediatric anesthesia is, without question, mastering developmental physiology. The key differences in clinical practice all stem from that intersection of high consumption rates, severely limited functional reserves, and the anatomical susceptibility of the airway. Every single choice we make, from using sevoflurane for induction to calculating the precise fluid rate to ensuring continuous warming, is dictated by these non-negotiable physiological realities. The ultimate safety net you carry isn't a formula, but a deep, internalized understanding of why the infant patient is different.
so what does this all mean for the future of practice? We've seen these incredible advancements in safety protocols, all driven by registry data and physiological understanding. However, the discussion about the developing brain remains open. Given the increasing and ongoing body of evidence suggesting an association between early exposure to general anesthesia and adverse neurocognitive outcomes, whether that relationship is definitively causal or confounded by the necessity of complex surgery in vulnerable children, how will the anesthesiology field evolve monitoring and technique? Perhaps by increasing the use of regional blocks or altering specific anesthetic choices like favoring TIVA over volatile agents to absolutely protect the developing brain in the youngest and most vulnerable patients, ensuring that neurodevelopmental safety is secured alongside absolute physiological safety. That challenge, mitigating the long-term unknowns, is what will define the next generation of pediatric anesthetic practice.